Thank you, Marco. Well, in the last two presentations, we heard about chronic allergic problems that can result in a lot of mind devils. Okay. Now we are talking about an acute problem that may only happen once or twice in a patient's life, and yet it can produce an equal amount of mind devil. It doesn't bother these patients most of the time, and yet they always live with the fear. And so it is equally important to understand, how they feel, and practice of medicine is not really just to cure the disease, but of course to treat the whole patient. So what is anaphylaxis? Anaphylaxis is a serious allergic reaction that is rapid in onset and may cause death. And there aren't too many allergic conditions that can cause death. And there's no kind of hard and fast rule, but generally we accept certain scenarios as being anaphylactic. So, for example, let me see, is there a pointer? You got, okay. Oh, thanks. Yeah. Okay. So in the first scenario, we have skin and mucosal involvement, plus respiratory symptoms such as wheezing, shortness of breath, or signs of cardiovascular involvement. Or secondly, all three plus GI symptoms when we do not have an absolute certainty of exposure. So this will, or sometimes in exposure to a known allergen, which result just in a lowering of BP or shock. So even that alone can sometimes happen in the absence of other symptoms. And that's very important because sometimes we don't see any skin symptoms and we think this is something else, but it could also be anaphylaxis. Many things can cause acute allergic reactions, the most common, of course, being food, insect stings, not as uncommon as one thinks, actually. Things that we give to patients, like drugs, biological agents especially. And then other things to consider would include latex, occupational allergens, even seminal fluid. You have to, of course, understand the patient's lifestyle, so sometimes it could be things that they come in contact with during leisure time, and what we call anaphylactoid reactions due to certain IV substances such as the radiocontrast. And one of the things that's overlooked, and I'm glad Alice talked about, is traditional Chinese medicine, because that's one area that we don't have a lot of literature in, because basically nobody's really studied TCM as a source of allergy. But it is actually very important, because when the patient is given traditional Chinese medicine, usually it's really a concoction of many different herbs, and each herb might contain thousands of different compounds, as well as heavy metals and pollutants and pesticides and things like that. So it could actually cause very complex kind of situations. In terms of food, in children, most common will be this list of foods, but the most deadly usually would be nuts, peanut, and shellfish. But important to remember, though, that any food can actually be a cause, so do not overlook other possibilities. Insect stings, again, not uncommon here, so it's important to take a history. I've even seen a patient who went to Australia for a holiday and had a fire ant bite and actually had severe anaphylaxis. So when traveling, you also have to watch out, because there are areas that have this kind of problem, and people living in Hong Kong are not kind of aware of the pitfalls. Oops. And then another important trigger would be medications, and the most important, of course, would be antibiotics, and non-steroidal and anti-inflammatory drugs. These can result in different kind of presentations. If there is any doubt at all, you should refer patients for testing. And let's talk about latex. In fact, latex is no longer used in many countries for medical purposes. But in Hong Kong, they are still used quite frequently. And be aware that there are certain types of people who are particularly at risk, such as healthcare workers, of course, but also children who's had multiple surgeries, such as those with spinal bifida. And then there are physical causes of anaphylaxis, the most common of which would be exercise-induced anaphylaxis. So when you come up with a history, find out if these reactions are associated with exercise or sometimes with heat or even cold. And in about 50% of cases of exercise-induced anaphylaxis, these are also related to food ingestion. Wheat or gluten being the most important allergen in this case. And then also remember that there are cofactors that could increase the risk of anaphylaxis or the risk of death in anaphylaxis. And some of these might be related to the patient's health, but also to his or her mindset. For example, the highest risk for fatal food anaphylaxis would be actually in adolescents and teenagers and young adults. It's because, sometimes, especially boys, they sometimes get carried away and they don't take care of themselves. And oftentimes, when you look at review cases of fatal anaphylaxis, alcohol and drugs are actually present. And I remember a patient, a young man who just graduated from university in the US, came back to Hong Kong and had an anaphylactic reaction one night. So his mom brought him to me, and we took a history, and we kind of explored everything, and we couldn't really find out much. And then a couple of weeks later, he came back with another episode, and this time he came alone. And then when I talked to him, he admitted that, in fact, that night he was out with friends and he was smoking marijuana. And so I thought, well, this could well be, marijuana problem. And then it turned out, in fact, that he also had bak guo at home one night, and then he had another anaphylactic reaction. And it turned out that he was actually allergic to ginkgo, bak guo, which is a nut. And when we tested him, of course, he was allergic to nuts. So in the club, he was smoking marijuana, but he also dipped his hand into a bowl of nuts, and he ate some nuts. But he was so stoned that he couldn't remember what he did, so we wasn't able to get that part of the history. So when a young man is kind of has some alcohol, has some marijuana, they don't really know what they were doing. So this could be a problem. And then in older patients, of course not in children, but in older patients, patients with asthma or pre-existing cardiovascular diseases are, of course, at higher risk. And there are certain drugs that are particularly harmful. So, for example, ACE inhibitors and beta blockers both can blunt the body's response to kind of to compensate for a low blood pressure during anaphylactic reaction. So if the patient is on these drugs, then when they have anaphylaxis, it could make the problem a lot worse. But also remind your patients that other situations can worsen anaphylaxis. For example, exercise. So if they've been exposed to an allergen and then they exercise, this could make the anaphylaxis much worse. Or if they've taken an aspirin, for example, or another NSAID, that could also make the anaphylaxis much worse. So signs and symptoms, we kind of talked about that a little bit, but cutaneous symptoms would include, itching, urticaria, swelling. Patients may have nausea, vomiting, abdominal pain. They may feel, they may be sneezing, have nasal congestion, throat tightness, shortness of breath, chest tightness, wheezing, feeling faint. So these are all symptoms of anaphylaxis. Now, anaphylaxis can also behave in different ways. So, for example, this could be kind of like a single phase or uniphasic response where the symptoms started very soon after the exposure, peaks within minutes, and then with treatment or without treatment, it goes away. Or sometimes it could be a biphasic reaction, where after the initial symptoms subsided, within about 8 hours, you get a second or late phase. Okay, and now most of the time, the late phase is not as severe as the initial phase, but sometimes it could be. And so the mistake is, a patient treating himself at home, feeling better and thinking that it was over, went to bed or something like that, and then had another reaction while asleep. Or going to the hospital and being released too early, going home and having the same kind of problem. So be aware of this possibility. Or sometimes the anaphylaxis can be protracted and unresponsive to treatment. So when we come up with a patient suspected to have anaphylaxis, there are certain points that we need to consider. So, for example, what is the suspected trigger? So that we have to try to get a very complete history, exactly what the patient has been exposed to at the time of the reaction, the amount of the allergen exposed, and the timing of the symptom. Usually anaphylaxis occur very quickly, but sometimes you can have a late phase response even without or with a very mild initial phase. How well did the symptoms respond to treatment? And associated factors. Were the patient exercising before this happened? Did the patient take any medication on that day? What did the patient eat? Was the patient sick? If the patient is having another infection, they could be more prone to severe symptoms. And of course, was alcohol involved? Now, there are some lab tests that could help us make the diagnosis of anaphylaxis. So if the patient presents within a couple of hours of the onset of symptoms, we can take a tryptase, a serum tryptase. This is not a terribly sensitive test, but if it comes back positive, then this would give us an idea, give us a stronger reason to believe that it is anaphylaxis. Histamine, however, is not as useful because the half-life is much shorter. And then the second type of thing we should do is to try and look for the reason. And we can test directly using skin testing or blood IgE testing. However, this should be based on patient history because these tests have false positives. And so we need to have a good pre-test probability, otherwise we will just be confused. So take a very good history, write out a list of suspects, and test those directly. And always remember, the presence of allergen-specific IgE, either shown by a positive skin test or a positive IgE test, does not mean that the patient is allergic, just means that there is sensitivity. So at the end, you have to try to correlate this with the patient's history. And if there is any doubt, then we might need to move on and do challenge studies. And then finally, the most important and most effective treatment for anaphylaxis is epinephrine or adrenaline. It's not steroid this time, and it's not antihistamines. Okay? So, and there is no harm in using epinephrine even if it is not necessary. But there is a lot of harm if we delay the use of epinephrine. All the studies showing fatal outcomes of anaphylaxis, almost always the patient either had not received epinephrine or did not receive it early enough. And if the epinephrine is given early enough, there's almost always survival. Okay? And remember, epinephrine must be given by IM route, okay? Because if you do it subcutaneously, the absorption is erratic. And it has to be given into a large muscle, such as the quadriceps. So the dose would be, in adults, 0.3 to 0.5 milligram IM, and in children is 0.01 milligrams per kilogram. And of course, as time is important, it's very helpful if the patient can carry a device that can inject epinephrine. And in these kinds of situations, it's best to have an auto-injectable device where the patient can be trained to use reliably. And so the patient must be prepared in situations where they're at risk of having reactions. They should always carry the epinephrine. So recognize the symptoms early and then respond quickly by giving the epinephrine. And then afterwards, try to review and write down what might have caused the reaction. And always tell the patient, if in doubt, just use the epinephrine. Thank you.